it's nice that right before the break we were starting to talk about principles of treatments and mechanisms in treatments. That kind of segues nicely into thinking about this topic as well. So I think I'm actually, in talking about this, I'm going to start quite broad, because I think when we want to think about what treatments are aiming to do, we want to think about where people want to be ultimately. And I think social psychology provides us a nice roadmap of what that is. There's an extensive body of research in social psychology showing that we really want to belong. And when we don't belong, we don't feel good. So we want to feel connected. And all of our cultures give us ways to belong. They give us a roadmap. They give us things to do that will help us to belong. So we try to do those things, and that helps to define our identity. But we do those things relative to the people who are around us. So we want to belong, but we also want to be slightly distinctive. So we know who we are and how we fit in with other people. So we want to have a sense of identity, those goals that we were talking about before. And there's also, obviously this isn't the exhaustive kind of list, but we're hopefully always learning and developing along as life is going to happen to us. And hopefully in therapy we're helping people to flexibly learn and be able to adapt so that they can develop their senses of identity and to belong. Okay, so how are we helping people to do that? Now again, this is not an exhaustive list, but these are some key candidate broad themes that we might be thinking about. We know from a lot of different therapies, so it's not just BA, it's not just CBT, but that if we reduce avoidance and we improve approach, then people tend to do better. We can't just avoid our problems, we can't avoid our goals, we have to actually go and do these things. We have fear, we avoid things that we're fearful of. If we do that, we'll narrow down our lives and we can't then belong and have a good sense of identity in which we're achieving. We also want to reduce overgeneralization. So some of you today have presented on cognitive mechanisms, and some of you have already talked about how kind of overgeneralization in our cognitive thinking is not helpful. Being more abstract is often not helpful. It reduces our problem-solving abilities. So often we want to get less overgeneral in our thinking about the present, about the future, and about the past, and we want to be more specific. And probably key to everything is when people get into, and we all do this, we all get into ways of behaving and thinking that become habits. And we might rigidly approach a range of different situations and contexts in a rigid kind of way, and it's using the wrong strategy for the wrong context or the wrong time. And that rigidity is unhelpful. So often what a lot of therapies are trying to do is to improve effective response and improve flexibility. So those are some big, broad kind of themes that we're trying to do. So how do we do that across different treatments? Lots of different ways. We've talked about BA today. Behavioral activation will try to work around behaviors and trying to get people to change their behaviors, to approach things more, not avoid things as much, to respond in flexible ways. We've talked about thoughts. There's a lot in CBT, cognitive behavioral therapy, about changing your thoughts, restructuring your thoughts, not getting stuck in repetitive cycles of thinking that are very abstract. We do problem solving. We have treatments that focus really on relationships, communication, reducing dysfunctional communication or just communication that isn't very effective. And we also have treatments, all of our treatments probably to a certain extent focus on understanding patterns or ways of being, just hopefully, what I'll say in a moment, but hopefully they also focus on some really practical skills as well, because that does make a difference. Okay, so does one approach work better than another? That's great. Well, for meta-analyses, probably not. That's in broad brush. So in depression, there's been a number of meta-analyses that have looked at the treatments that have been researched at least, and as Miranda was saying, a lot of treatments actually haven't been researched, so we don't know. We can only do meta-analyses on what's out there. But of the treatments that have been researched, it looks like for depression there isn't one that's probably superior to another. Although the treatments that involve practical components are superior to supportive treatments. For PTSD and anxiety, most of the evidence base is around CBT and exposure-based treatments, and those are definitely superior to supportive treatments. But if we're trying to compare things like interpersonal psychotherapy, or if we're trying to CBT, to problem-solving therapy, to behavioral activation, one is not better than the other by broad brush meta-analytical results. But we might want to look at the detail. What should we do? How should we pick what's going to work best in a global health context? There's probably a few things that we want to think about. So if they're all kind of similarly efficacious, first maybe we want to think about the face validity of the intervention. Does the strategy make sense to the individual? Because if it does, they're probably more likely to use it. Is it easily transferable across context, age, and cultures? I had a lovely moment when I was training some peer supporters for one of Alan's trials down in South Africa, and I said, just tell me first, you know, the way that you think about things, do you think about trying to change your thoughts? And they were like, I said, oh, okay, well, that probably isn't going to be transferable immediately to you or have great face validity. But when we talked about more concrete and behavioral strategies and rumination, they got it immediately. So we need strategies that are really easily transferable. They need to be, as we talked earlier today, easily trainable and supervised. Now we're having a little bit of a debate today. Is it okay to have kind of peer supporters, lay workers, deliver these things? Well, maybe, maybe not. How trainable is it? And I'm going to talk to you about a trial about that. How easy is it also to supervise people on those things? Because supervision makes a huge difference. Is it easy for the people who are doing it to learn it? Is it easy for people to sustain that? Is it easily reinforced in their environment? If it's really hard and cognitive, it takes a lot of cognitive work to do something, it's not easy to sustain. And do the strategies of the treatment match the principles, the broad principles that we're going for? Are they flexible themselves? Probably overall, we also want to stay focused, and as I've mentioned before, when things get complex, stay simple. So here I'm going to talk about I'm obviously a fan of behavioral activation. So the meta-analyses say that probably there aren't differences, but if we drill down into treatments and look at factors within treatments sometimes, we discover that maybe there might be some differences. So I'm going to talk about a trial of CBT versus BA versus antidepressant medication. And in this one, what they first looked at was the rates of attrition by condition, and they found that similar rates of attrition in CBT and BA, but higher rates in antidepressant medication, so maybe that's less acceptable. But here's a really interesting finding that they got. Now these are kind of classic results here by now. So you'll see that all of these lines are about the same. So this is antidepressant medication for people who have severe depression and not severe depression, and for BA, also severe and not severe, less severe depression. Also depression doesn't feel very good. But there's this weird one here, this outlier, and that is CBT for people who have severe depression. Those folks did not respond as well to the treatment. And in fact, if you look at people who had kind of severe, very severe depression and didn't respond, so had extreme non-response, the highest rates were in CBT. So this suggests that for very severely depressed folks, CBT doesn't work as well. It's a more complicated treatment than, say, BA, so maybe it requires more skill. We did a subsequent trial, it's the COBRA trial. It was a non-inferiority trial comparing behavioral activation and CBT. We trained kind of, we call them Band 5 folks here. They're folks who have about 1 year of mental health training, to very skilled therapists. And what we found was they were totally the same. The means and standard deviations were the same. So they produced the same outcomes. In this trial, we didn't see effects by severity of depression, but notably, BA was delivered by folks who had significantly less training. Lots of supervision, just as much supervision as the CBT folks, but less training overall. So it was cheaper to deliver. We've done some subsequent analyses looking also at whether at specific points in treatment, if there are differences in longer-term outcomes by whether people were receiving CBT or whether they were getting BA. So we looked at something called a sudden gain and something called a depression spike. A sudden gain is where you kind of suddenly improve in your mood. You've kind of a more stable mood, and then you suddenly improve, and then it's a bit stable after that. A depression spike is the opposite. You suddenly do worse. Probably something bad has happened to you. And what we found is that for folks in CBT, if individuals had a depression spike, they did worse long term. So if there was a sudden worsening, they did worse long term. Something stressful happened in their lives. That didn't happen in BA. They stayed steady. They didn't get worse, and over time they remained well. The flip happened though with a sudden gain. Folks who had a sudden gain in BA did well. Folks in CBT who had a sudden gain did even better. They did really, really well. They might have even possibly been thriving by the end of it, although we didn't measure thriving per se. So in sum, we want to think about treatments that are transferable, are easy to implement, and think about specifically who they might be working for better, and also maybe what strategies are best to implement when. Okay, and that's it. I think I'm done.
Great. And our next, we're ready.
I'm training just because I think I may have left my phone behind.
Yes.
I'm trying to find it. Sorry about that.
Our next speaker is Crick Lund, and Crick is Professor of Global Mental Health and Development at King's College London, and he has also got a post at UCM at UCD still, and he's going to give us the next talk in the subject.
Great, thanks. Good afternoon, everyone. It's really been a fantastically stimulating day, so thanks again to the organisers, and thanks for the opportunity to speak. What I'm going to say actually dovetails very nicely with what Heather had to say. So I'm going to start off by just pointing out how rapidly this field of psychological therapies in low and middle income countries has developed over the last year. Since 2003, there were some landmark studies. Ricardo Araya and Graciela Rojas in Chile, Paul Bolton and Tony in rural Uganda, and Vikram Patel in Goa in India published the first landmark psychotherapy trials showing these interventions to be highly effective, and also publishing them in top journals in The Lancet and JAMA. And since then, there have been a whole bunch of people doing more and more psychotherapy trials. So it's a really exciting time to be working in this field. And a very nice summary of this whole area, for those of you who are interested, has been put together by Daisy Singler and colleagues. This is a systematic review and meta-analysis of 27 randomized control trials, largely using task-sharing interventions delivered by non-specialist health providers on common mental disorder outcomes. And you can see a pooled effect size or standardized mean difference of about 0.49, which is remarkable if you think about who's delivering these interventions and the circumstances under which they're delivered. But the question immediately arises, and Heather was touching on this, which therapeutic approach is best, which is most effective, but also which one can we most easily translate across different cultural and age and socioeconomic contexts. And I think there's some danger in trying to identify which, because there's a lot of evidence that there are similar outcomes across these. And one of the books that I found really helpful, published in the late 1990s, which makes this argument, is called Escape from Babel, published by Scott Miller and colleagues. And really trying to say, across these different psychotherapeutic approaches, aren't there common elements or shared components which make them effective? Things like the therapeutic rapport between the therapist and the client, the level of trust, the level of empathy, and to what extent do these common components explain some of the outcomes that we see. And to some extent this is true. This is a large systematic review and meta-analysis or meta-analytic review that Tim Capers and colleagues have done. They've taken 385 randomized control trials. I don't know, one to think about how many hours that took to pull together. But a pooled effect size is about 0.72. But if you scan across these, you'll see not huge differences in outcomes. Perhaps, maybe this is supporting Heather, and I'm sure Michelle would also be happy to see this. Some outliers, behavioral activation showing particularly good effects, and then psychodynamic therapies and supportive therapies less. but actually not a whole lot separating these. So is this about specific techniques associated with particular therapeutic approaches, or are there common components? Well, the short answer is that it's complex, and Pim puts this really nicely. He says, it's still unknown whether therapies work through common or specific factors, or both. And this is really because of the state of the field. Currently, a lot of trials don't really do mediation analysis, which allows us to assess the extent to which particular mechanisms are associated with particular outcomes. To establish that a mediator is causal, studies must demonstrate a temporal relationship between the mediator and the outcome. They must show a dose-response association. They must control for third variables, and they also must have a strong theoretical framework. So if we're thinking about research agendas for this field, we really need to be thinking in more mechanistic ways, trying to look at more carefully about what are the particular mediators that have these outcomes, either mediators that are common across disciplinary approaches or therapeutic approaches, and those which are specific to those particular approaches or techniques. And circling back to Daisy Singler's review, she puts this very nicely, and she's and colleagues have put together this very nice taxonomy of treatment components. And some of them are non-specific. They relate to engagement processes between the client and the therapist. Things like collaboration, empathy, active listening, normalizing a person's experience, and so on. These are really important to track in our psychotherapy trials. But also some of these treatment components are specific to particular approaches. There are particular behavioral techniques, there are particular cognitive techniques, interpersonal techniques, and emotional techniques. And so when we're thinking about evaluating psychotherapy interventions, either on their own or in conjunction with cash transfer trials or other poverty reduction instruments, we need to be careful to think about documenting these, and if possible to try and assess their impact in a more mechanistic way. And all of these can be expressed in a variety of different in-session techniques. So getting back to the question which I've been asked to try and address, what are some of the key issues that we need to think about when translating these different interventions across contexts? Well, definitely culture and age, really important. A great example of this is Dixon Chibanda and colleagues' friendship bench intervention, which I think not many people know was embedded for about a 5-year period before the main trial was actually run. So the gohos, or the grandmothers who actually deliver the intervention, had a long time to actually adapt what we in the West might call problem-solving therapy to something which was much more aligned with indigenous idioms of distress, using terms like ufungisisa. The opening session of the intervention is called opening the mind, and you probably wouldn't see that in a problem-solving therapy manual. So there's a whole lot of cultural adaptation that I think we need to be thinking about when we do these trials in different contexts. But also, really importantly, we need to be thinking about the processes of delivering these interventions. And we did quite a lot of work on this in the last 8 years or so through the PRIME collaboration. This was a DFID-funded research consortium working in 5 countries in Ethiopia, India, Nepal, South Africa, and Uganda. And we did a lot of work on what are the optimal health system environments for delivering these psychological therapies. Who should be the delivery agents? What kinds of training do they need? What intensity over what period? What kind of supervision should be in place? What kinds of fidelity measures should we use, and how do we document fidelity to the intervention? And then also, what are these kind of non-specific elements? Brandon Court has done a fantastic job of developing this tool called the ENACT tool, which tries to document some of these non-specific components to delivering psychological therapies. And also, how do we adapt these and deliver them in contexts of socioeconomic adversity and humanitarian settings. So I wanted to bring things to a close by just also reflecting on what didn't work. So we spent 5 years doing this trial in Khayelitsha, which is a large peri-urban settlement on the outskirts of Cape Town, home to almost 500,000 people. And it was focused on maternal depression, so we enrolled antenatally depressed mothers, and the intervention was delivered by non-specialist community health workers. And after much effort, much attempts to develop the intervention in a way that would be appropriate, we found a non-significant outcome. Only 55% of the women in the intervention arm showed a clinically significant response at 3 months postnatal, and 47% in the control arm showed a response. There are a number of reasons, but I think among them are some of the issues that Michelle touched on earlier today, which is that it's really important to have an intervention that is focused, that repeats and allows people to practice and develop skills in a particular way. Our intervention was quite complex. Secondly, the community health workers themselves were dealing with very difficult life circumstances, the same circumstances that our clients were facing on a day-to-day basis. And third, we had a lot of trouble with assessing fidelity, and it's very difficult to do this in a way that doesn't influence the outcome. But going back to some of the transcripts, we're finding fairly clear evidence that community health workers were reading from manuals, sometimes reading the material that was meant to be instructions to themselves, to the clients. So a whole lot of things that were going on with the implementation process. I think it's really, really important to pay careful attention to implementation and supervision in these settings. And then finally, in terms of a research agenda, there's a whole bunch of stuff we could do. It's a really exciting area. We need to do a lot more work on understanding local, culturally valid idioms of distress, understanding more about the qualities of the therapist, especially if we're working with non-specialist health providers that would enable them to be effective, measuring fidelity, measuring mechanisms and doing really robust mediation analyses, as I mentioned, incorporating trans-diagnostic approaches along the lines of what I've been suggesting, and modular approaches which allow more tailored interventions to the needs of particular clients. And then also this huge gap around interventions for children and adolescents. And the list could go on. I would also add digital interventions, which Michelle is going to talk to you about now. And also linking some of these interventions with other poverty reduction interventions. So thanks very much.